కౌంట్ 9 మెంబర్స్ ఉన్నారు అందుకనే 5 minutes వెయిట్ చేద్దాం.
Okay, and by that time you please share the screen, no? I'll see.
Okay, ma'am. I'll do that.
Yeah. May I know Susila Garandi? May I introduce yourself, ma'am? Please unmute yourself, ma'am.
Susila is the current president of Vijayawada OB-GYN Society.
Oh,
She is the secretary of Vijayawada Menopausal Society.
okay.
And she is the MTP committee member.
Member also.
Okay.
Yeah.
Hello, madam. Good afternoon, madam. Nice to meet you.
Same with me, madam. Meeru nunchi.
నేను నల్గొండ ఓబీజీ సొసైటీ మేడం, నేను సెక్రటరీ మేడం. పాస్ట్ 3 years నుంచి నేను అక్కడే వర్క్ చేస్తున్నాను, అంటే నల్గొండ ఓబీజీ సెక్రటరీగా చేస్తున్నాను మేడం. ప్రెసిడెంట్ గారు వచ్చేసి డాక్టర్ సుచరిత కొసరాజు.
సుచరిత గురించే మాట్లాడుకుంటున్నాం నేను పద్మజ ఇప్పుడే. అంటే పోయిట్ కూడా కదా.
అయ్యో మేడం, షీఈస్ టాలెంటెడ్, మల్టీ టాలెంటెడ్ మేడం.
మల్టీ టాలెంటెడ్, నాట్ ఓన్లీ పోయిట్ అన్నమాట.
నాట్ ఓన్లీ ద అంటే ఎడ్యుకేషన్ అంటే యాజ్ ఎ ప్రొఫెషనలిస్ట్ గా కాకుండా మేడం అన్నింటిలో ఉంటాయి. అండ్ షీ విల్ బి వెరీ ప్యాషనెట్ ఫర్ ద కల్చరల్ యాక్టివిటీస్ కానీ. అండ్ దెన్ మోర్ ఇప్పుడైతే ఇంకెప్పుడు ఎలా ఉన్నారంటే, బికాస్ హర్ చిల్డ్రన్ వాజ్ సెటిల్డ్, నో, సో దే స్టార్టెడ్ ప్రాక్టీసింగ్ నల్గొండ. సో మేడం ఎక్కువగా ఇక్కడ అడాలసెంట్ హెల్త్ ఎడ్యుకేషన్ మీద బాగా కాన్సన్ట్రేట్ చేస్తున్నారు. అండ్ అలాంగ్ విత్ అవర్ సొసైటీ, అంటే ఆన్ బిహాఫ్ ఆఫ్ అవర్ సొసైటీ ఆల్సో వీఆర్ డూయింగ్ సో మెనీ పర్సనల్ హైజీన్, మెన్స్ట్రల్ హైజీన్, అండ్ దెన్ అడల్ట్స్ అండ్ హెల్త్ ఎడ్యుకేషన్స్ అవన్నీ కూడా పాస్ట్ గా మా ఓన్ గా చేస్తున్నాం. ఇంక ఇప్పుడు దే అలాటెడ్ ఇన్ ధీరా అన్నమాట. ధీరా మీద పెట్టారు కాబట్టి వీఆర్ డూయింగ్. కాకపోతే కొంచెం ఆ రిజిస్ట్రేషన్ పార్టే కొంచెం కాంప్లికేటెడ్
గా మేము కూడా చేస్తున్నాం మేడం. ధీరా బాగానే చేస్తున్నాం. 14 schools
విజయవాడ వాళ్ళు బాగా చేస్తున్నారు కదా మేడం. ఐ థింక్ మోర్ దాన్ 15 schools ఈ ఫినిష్డ్, ఐ థింక్ సో. దట్స్ అ వెరీ గుడ్ పార్ట్ మేడం. మీరు ఎలా మేనేజ్ చేస్తున్నారు రిజిస్ట్రేషన్? కొంచెం ఇబ్బంది అవుతుంది నాకు, మా పిల్లల్ని పంపించి రిజిస్ట్రేషన్ చేయాలి.
సేమ్ అండి, కాకపోతే శైలజ అని సెక్రటరీ ఉన్నారు, తను చూస్తున్నారు.
అవునండి, తను బాగా చూస్తున్నా. మొన్న కూడా మన మేడం కనిపించారు మొన్న దాంట్లో. యా మ్యామ్, షీ ఈస్ ఫ్రమ్ వేర్ మ్యామ్? డాక్టర్ శైలి అగర్వాల్. హలో, గుడ్ ఆఫ్టర్నూన్ మ్యామ్. ఐఎమ్ డాక్టర్ మంజుల.
Good afternoon, Dr. Manjula.
Good afternoon, ma'am. May I know where from you, ma'am?
I am from Kanpur, a city in UP, Uttar Pradesh.
Okay. Oh, nice to meet you, ma'am. We are from Telangana state, ma'am, and I am from Nalgonda OBG Society, and Dr. Padmaja and Dr. Susila are from the Vijayawada.
So nice to meet you, all of you.
Yeah, all of you. Yeah.
My brother studied in IIT Kanpur a long time back.
Oh,
okay.
It was, I mean, at least that time they used to tell city of guns and leather.
Yeah, it is city of leather.
Yeah, now my son is, and my son means my sir wala brother. So means chacha ka boy mera means my son is now he admitted in first year, madam, in Kanpur.
Oh, in GSVM itself.
Yeah. Kanpur.
Okay.
Kanpur
I am professor there at the GSVM Medical College Gynae department.
IIT.
No, IIT, ma'am. IIT, not of medical, madam. Not of medical. IIT Kanpur. Mechanical he joined.
Great. So he was not interested in medical line.
No, ma'am. No. बचपन से देख रहे ना हमारा पोजीशन and how we will be suffering in our clinics and mentally, physically, medically, physically. No, they are not interested.
They are not interested.
And we are also not forced him to come to this.
We should not force their kids, no? It's their life. They should decide what they want to become.
Yes. ఇంకా I think madam garu and baga and we are conducting our TCOG this time, our turn, madam. Nalgonda OBG Society is hosting TCOG. It is in August 13th and 14th, ma'am. Just 1 week back only the date were decided. And so we are soon we will release our brochure and everything. Please, you have to participation from your societies also, ma'am.
Definitely, please
Definitely, we'll send a mail and everything.
circulate the mail and flyers. No, we'll definitely ask her.
Yeah.
ఫిజికల్ చేస్తున్నారా వర్చువల్?
లేదండి, ఓన్లీ ఫిజికల్ ఏనండి, నాట్ వర్చువల్. వర్చువల్ ఎందుకు, ఇక ఫిజికలే చేద్దామని డిసైడ్ అయిపోయాం. లాస్ట్ ఇయర్ we want to do a hybrid depending on those situations అన్నమాట. మళ్ళీ అది కూడా పోస్ట్ పోన్ అయింది బికాస్ ఆఫ్ సెకండ్ వేవ్ తోటి. సెకండ్ వేవ్ వచ్చేసేసి అది కూడా పోస్ట్ పోన్ అయింది. సో దిస్ టైం మాత్రం వీ కన్ఫర్మ్డ్ ఓన్లీ ఫిజికల్. నల్గొండ టౌన్ లో చేస్తున్నాం, అంతకుముందు కామినేనిలో చేసాం కదా. ఇప్పుడు కామినేని మేనేజ్మెంట్ కొంచెం మారింది, ఇంకా అందుకని వీ వాంట్ టు గో ఫర్ ద నల్గొండ ప్రైవేట్ కన్వెన్షన్ సెంటర్ లో చేసేస్తున్నాం. బాగుంది, ఏసీ హాల్ అదంతా బాగుంది. ఎందుకంటే ఇప్పుడు ప్రతి టౌన్ లో కూడా చాలా వచ్చాయి గుడ్, అంటే స్పేషియస్ గా ఉన్నాయి, గుడ్ గా ఉంది. సో ఇంకా అప్పటికే మనకి రైనీ సీజన్ కదా ఆగస్ట్ అంటే, అందుకని ఇంకా నా డేట్స్ కూడా బాగానే డిసైడ్ చేశాను మేడం గారు. 13th and 14th అంటే ఆఫ్టర్ రాఖీ వచ్చేసింది, 12th is రాఖీ అండ్ 15th ఆగస్ట్ కూడా సెలవే కదా. సో మన డాక్టర్స్ కి కొంచెం ఓపీస్ మేబీ ఎలెక్టివ్స్ ఉండొచ్చు, ఓపీస్ బాగానే ఉంటాయని అనుకుంటున్నాం, అంటే ఓపీస్ తక్కువ ఉంటుంటాయని అనుకుంటున్నాం. అట్లా మీరు అంతకుముందు ఇలా చేశారా మేడం మాస్టర్? అంటే
సొసైటీ అయిపోయినాయండి, 3 programs అయిపోయినాయి. పద్మజ అయితే ఇంకా వేరే సొసైటీస్ కూడా షీ వాస్ ట్రైనర్ ఫర్ అదర్ సొసైటీస్ ఆల్సో.
అవునండి. అచ్చా
మేడం, did you do all this program, ma'am? Like RAC program is over in your society, Dr. Shaili?
Yeah, we are doing the program.
Okay.
ఇది మాది ఫస్ట్ టైం అండి, ఇది ఫస్ట్ మా ట్రైనింగ్ ప్రోగ్రామ్ టు అవర్ మెంబర్స్. And we circulated this link to other societies also. I posted in our TSPS secretaries WhatsApp లో కూడా. నిన్న కిరణ్మయ్య గారు చేశారు, నిన్న కిరణ్మయ్య గారు 19th రోజు చేశారు సేమ్.
ఓకే, సో we have a membership in Vijayawada of 350. Susila? 350 and 200 members are already trained. We have
350 నే ఉన్నారా మేడం మీ సొసైటీ టిల్?
విజయవాడ అంటే we have ఏలూరు, గుంటూరు, ఒంగోలు, all societies.
ఓన్లీ విజయవాడ is holding 350 members మ్యామ్. అంత తక్కువనా?
మీది ఎంతమంది అండి?
మాది 108 మ్యామ్. విజయవాడ నల్గొండ డిస్ట్రిక్ట్ అంటే ఓన్లీ టౌన్ వరకేనా ఇది?
Vijayawada, Krishna district. For us now, all are within 20-30 kilometers distance. We within 30 kilometers. We have Elur, which is 30 kilometers.
Oh, that's why
we have Bhimvaram society also very close by. So small place, no? So
I thought that it should be more than 500 undochu ani anukunnanu. Vijayawada
Vizag society covers lots of districts. That has 500.
Okay.
So since we have, it's already 210 and we have
only 13 participants. మనకు 13 participants వచ్చారు. అపార్ట్ ఫ్రమ్
that 4
are మనమే ఉన్నాము, శ్రీమాన్ ఉన్నారు. సో 9 వచ్చారు మేడం. ఇంకొక 5 minutes చూసి we start మేడం. మనం చేసేద్దాం, ఎందుకంటే టైం మళ్ళీ పర్మిట్ అవ్వదు, ఇబ్బంది అవుతుంది. మనం స్టార్ట్ చేసేద్దాం. లెట్ ద మీన్స్ జాయిన్. నేను ఒకసారి మా సొసైటీలో పెట్టేస్తాను, జాయిన్ అయ్యింది.
I spoke to Ajay sir madam, he told to start the program also.
Yeah, definitely అండి, మనం చేస్తాము. మీరు చేస్తారండి స్లైడ్ షో శ్రీమాన్ గారు?
Yes ma'am.
అది కొంచెం బాగుంటుందేమో. నేను షేర్ స్క్రీన్ అని కొట్టాలా?
నెక్స్ట్ టైం చెప్పండి,
యా డెఫినెట్లీ అండి. థ్యాంక్ యూ. చేసేద్దామా మరి? Yeah. Hello, good afternoon everybody. Welcome to this RAC training program which was launched by our beloved president Dr. S. Shantakumari madam garu, so that we can increase the respect to the who is going to abort, and then we should fulfill the goals of the aborting mother, and we should give a better medical care, so that her general condition may not go in a trouble. So that is the main aim of the medical termination of pregnancy. In this, we have so many acts are there, and we have whatever we are practicing to the previous act, we have some new amendments into this practice. That is, in 2021, we have new amendments to the existing law of the abortion, medical termination of pregnancy. That is, to this today we are discussing about the new amendments into this act. Sriman Garu, please show the slide now. And in our India, so the objectives of today's are what are all the new laws and what are all the changes in the rules. So what we with this, is there any benefit to the mothers who are going for the abortion? So let us look into that laws. So you all will be knowing about the MTP Act and MTP laws in the previous. Now we'll look into the new laws and new amendments into this law. Second slide. Sriman Garu, second slide, please. Yeah. So before going to know the abortion, so what are all the background to these abortions? What are the means? And so we are talking about the safe abortions, respectable abortion care. So we are using these words. But what are all these? If it is unsafe, means unsafe abortions in India lead to mortality, morbidity to the women and the girls. So to fulfill those unsafe methods, to decrease the unsafe abortions, we made some laws to the abortion care. So depending upon those unsafe abortions are carrying more 80% of the maternal deaths in is the cause for the maternal mortality in India. And nearly half the pregnancy are related deaths are in women, and girls are under 24 years. These are the major portion. It is occupying the unsafe abortions are occupying major portion. And nearly 2 out of 3 of abortions performed are deemed to be unsafe. So to decrease this number, to decrease this percentage, we are practicing the safe abortion rules. So in that safe abortion rules, we did our government of India made an MTP laws. Into that laws also we are amending a new protocols and new rules into that. So we are going to read, or we are going to know the new rules. Sriman, next slide. Next slide, please. Hello? Hello, Sriman Garu.
I've changed the slide, madam.
No. Yeah, next slide. Please go for the next slide, no? It's not showing in this. On screen, it is not showing, Andy. Yeah. So according to the World Health Organization, what is a safe abortion? Safe abortion should include both criteria. One is it should be done with appropriate methods, and it should be done by the trained person. If it is not fulfilling either of these two, it is not a safe abortion. It is considered as an unsafe abortion. Next slide, please. Next slide. Oh, it is taking. Mintu? Why the image is not uploading? Chinna idi.
Very slow.
Hello, Sriman Garu. I am getting slow, Nandi. Hello, is it audible? Hello, is it audible? I am audible.
You're audible, Andy.
Yeah. So,
Adi, Srimant nets lo unnattundi. You're audible, Dr. Manjula. Please go ahead.
Okay. So when coming to the salient features of the medical MTP amendment at 2021, so we have a modification is required to the previous act says that requirement of opinion on one provider of MTP up to 12 weeks. And the second is the requirement of opinion of 2 providers for MTP for 12 to 20. This is the previous act. But when the amendment has been done in the 2021, they changed from, they lifted this one to the before 12 weeks, and they added these 2 providers, means requirement of the opinion of 2 RMBs. RMBs means here registered medical practitioners. In further, we will be knowing the definition of RMPs by the WHO for termination of pregnancy 20 to 24 weeks of gestation. So with this, who will be going to benefit? So with this addition of this means we are lifting the one registered medical practitioner up to 20, and we ordered the 2 practitioners above the 20 to 24 weeks. With this, the increased number of facilities, especially in public sector like PHCs, eligible to service provision till 20 weeks. So the till 20 weeks, so more number of places and more number of the doctors will come into the practice safe abortion. And next second slide. Next slide, Sriman. Next slide, Sriman. Yeah. And this is another amendment which was included in this. The previous act says that MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. But according to the new act, enhanced the upper gestation limit from 20 to 24 weeks for special or vulnerable categories of women. That is, special or vulnerable categories means which is minor girls who underwent, and it means rape, or else any widows or any divorced cases. These are all the vulnerable categories. And further enhancement of birth defects not compatible with life on medical board consensus. So with these new amendments, so there will be an increased access for vulnerable women to safe and legal abortion services. Defined by rules committee includes violence of victims and minors among others. Second slide. Next. Yeah, this is another provision in the previous act. That is, in the previous act says that the act has provision for termination of such pregnancies only up to 20 weeks, whereas the upper gestation limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by medical board. So we saw previously, if there are any birth defects detected beyond the 20 weeks, we are very helpless to the mothers. Though they are detected birth defects, we are unable to do. Now with this the act, with this changing in the, or else with the addition of this act, we are increasing in access to safe and legal abortion services, who often seek services late beyond legal limit for termination of pregnancies with substantial fetal abnormalities diagnosed late. That is, late diagnosed birth defects. Now we can easily perform without any legal litigations, and thus reducing the unsafe abortions and court cases. So now mothers are more benefited, and practitioners also won't get any legal cases or any litigations when they are detected late birth defects to terminate the pregnancy. Because if any cardiac deformities, any other mental means brain deformities which are detected in a late TFOS or in 26 weeks or 28 weeks also, now we are enough, we can do safely, we can do some judge to those pregnant mothers who are come for the abortion. Next slide. And this is another amendment, that is the that what they have done is condition of failure of contraceptive to be extended for any woman or her partner. So previous act says that the condition of failure of contraceptive was applicable only for the married woman or her husband. Here it is only the marital status of the woman is more important in the previous act. With this, any woman or any her partner who are following, means nowadays the most of the girls are doing living relationships. So with that, if you have any failure of contraceptive, they can come and they can use these safe abortions legally. So with this potential outcome, there is an increased, with this addition of this rule, increased access to safe and legal abortions for any woman, irrespective of marriages, especially with upcoming changes in legal age of marriage, an important advancement of increasing access to safe abortion. Next slide. And there is an insertion of new clause for strengthening the privacy also, they have been added in this law. The previous act says that medical termination of pregnancy rule 2003 mentioned that information should not be disclosed except under authority of law. So we should keep a privacy of the aborting mother. But in this new insertion says that name and other particulars of women whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. Only means with this insertion, so there is an increase in privacy and confidentiality of abortion seekers, increased demand but not need to safeguard rights and dignity of women, and provide respectful bias-free services, including counseling and contraception. Next slide. Next slide. So the MTP amendment of 2021 prioritizes confidentiality and safety. So the same thing, they bought the previous slide, they are depicting in the picturizing. So the ground failure of contraceptive has been extended to women and her partner, and the name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being enforced. Second. Next slide. So on summarize, these are the rules under the MTP Amendment 2021 are. So first thing is it defines the special or vulnerable category of women eligible for extended gestational period of termination of pregnancy from 20 to 24 weeks, what we have been discussed in the previous slides. And second thing they have been done is the norms of the registered medical practitioner, means RMP, whose opinion is required for the termination of pregnancy at different gestational age. The powers and third thing, the powers and functions of the medical boards, OBGYN and pediatric plus radiologist, when available, formed for each state and mandated to provide timely evidence-based decisions. These are the three rules which were amended in the MTP Act 2021. And we'll see one by one what are the details of these rules. Next slide. So one, the special category of women eligible for MTP between 20 to 24. Who are eligible? So eligible one, the survivors of sexual assault or rape or incest. Second thing, the women with pregnancy in humanitarian settings or disaster or any emergency situation such as declared by the government. So in these cases, if the women are surviving and they got pregnant, which will be are detected late beyond the 20 weeks, those women are eligible for to go for the seek the safe abortions or they can use the MTP laws. And third one, change the marital status during the ongoing pregnancies. That is widowhood or divorce who are changing their marriage means their marital status, they are also eligible. So they need not to afraid of that how I have to bear this pregnancy, how I have to go with to the other person with this boy. So they may not be mentally tortured. They can come and they can use this MTP Act. And fourth category of women are women with physical disabilities, that is major disability as per criteria under Disability Act. They can also seek this MTP law. And fifth category are the mentally ill women, including mental retardation. And sixth category are the minor girls. And seventh are the fetal formation in this. And these six are the women categories who can who are the vulnerable women or a special category women, so that they can eligible to use this MTP law. And seventh one will comes the fetus, that is the fetal malformation that has substantial risk of being incompatible with the life, or if the child has born, it would be suffer from such physical or mental abnormalities to be seriously handicapped. This is the fetal cause. So there's where the birth defects are detected in a late trimester. So that mother also can use this MTP. Second, next. Yeah, second rule, the norms of the RMP. RMP defined in the old act as MBBS or more with any. So now they have defined in a very each particular way in this new amendment. That is, medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in a hospital, that person will be recognized as medical, that as a registered medical practitioner. Or as a medical practitioner who has completed 6 months of house surgery in obstetrics and gynecological department. Or else the medical practitioner who holds a postgraduate degree or a diploma in OBG. And medical practitioner who has experienced at least 1 year in the practice of OBG. So when you see in a picturized way, there's up to 20 weeks of gestation, 1 RMP opinion is needed. And up to 20 to 24 weeks of gestation, 2 RMP opinion is needed. And beyond the 24th, the medical board has to give the permission to terminate that pregnancy. Next slide. So again, in the norms of the RMP, under the amendment rules of 2021, an additional category of provider has been added for termination up to 9 weeks with the medical methods. RMP, that is registered medical practitioner with experience in practice of OBG at any hospital for 3 months is enough. And training with performance of 10 cases of MTP by medical methods of abortion under supervision of a RMP in a hospital established or maintained or a trained institution approved for this purpose by the government. So in the first trimester of pregnancy, that is a below 9 weeks, when we go for the medical methods of abortion, there will be the experience means the RMP's eligibility of RMP has been decreased from 6 months to 3 months in this new act. And they have been decreased from the 25 cases of MTP to performed cases. From 25 to they have decreased 10. These are the 2 new rules added to the RMP. Next slide. So the norms of the RMP whose opinion is required for termination at different gestational ages. So now they're giving is in a picturized mode, that is till 9 weeks. Experience and training requirement for RMP, that is registered medical practitioner. The first one is experience at any hospital 3 months is enough, or else independently performed 10 cases of MTP by medical methods of abortion under supervision of a RMP is required. Second rule is that is a practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 has been done independently in a hospital. Third is a practitioner who holds postgraduate degree or a diploma in OBG. And fourth one is a practitioner who has completed 6 months of house surgery in obstetrics and gynecology. And fifth is a practitioner who has experienced at any hospital for a period of not less than 1 year in the practice of OBG. So one opinion of 1 RMP is required, that is below 9 weeks, and that to be, these are the criteria of a to recognize RMP medical practitioner. Second slide. Next. Yeah. If we are aborting at 12 weeks, and what are the eligibility of an RMP? The RMP should be a practitioner who has assisted a RMP in the performance of 25 cases. Now, that is a change. Below 9 weeks is 10 cases, above 12 weeks is 25 cases. And here, the rest of all are normal. Rest of all are same as the previous slide. That is, he should be a postgraduate or else he should have a diploma or degree in a OBG, or else he should practice 6 months of housing in OBG, or else he should practice 1 year of practice of OBG. Is enough to do eligible to do MTP till 12 weeks. Next slide. And beyond the 12 weeks till 20 weeks. And what are all the experience or what are all the eligibility of an RMP? That is, one practitioner who holds postgraduate degree or diploma in OBG are eligible to do MTP beyond 12 weeks and up to 20 weeks. And second thing is a practitioner who has completed, means MBBS practitioner or else any DNB, 6 months of house surgency in OBG department. And third is a practitioner who has experienced at any hospital for a period not less than 1 year in practice of OBG. So it should be either PG of means a degree or diploma in OBG, or he should have an experience of 6 months or 1 year in OBG department. These are the criteria of an RMP, means these are the eligible doctors who can do a MTP beyond 12 weeks and up to 20 weeks. Next slide. And beyond 20 weeks, now this, according to the new law, we can perform 20 to 20, beyond the 20 weeks also, we can do an abortion. So in that cases, what are all the criteria? Same criteria as to the 12 to 20 weeks. That is, he should be a postgraduate or a diploma or degree. He should possess 6 months of housing in OBG, or else he should have a practice of 1 year practice of in OBG. So here again, 2 RMPs, opinion of 2 RMPs is required. Next slide. Beyond 24 weeks. Now here is the litigation. Here there the two opinions of RMPs are required to do 20 to 24 weeks. But if it is been 24 weeks, means which are what we have been discussed previously, that is a vulnerable woman or a minor girls, where in a pregnant woman where late detected birth defects. So in that there should be a PG in a OBG, or else a practitioner who has experienced any hospital for a period not less than 1 year in the practice of OBG. So these are the one, not a 6 months. And along with this, we should have an opinion of the medical board is required. If you are at all decided to do beyond 24 weeks of MTP, along with the RMPs, you should need an opinion from the medical board. And what is this medical board? We'll discuss in a further. In upcoming slides, we'll discuss what is this medical board, what are the functions of medical board, and how it is, what is the authority it is holding, who will appoint the medical board. We are going to know in the future slides. So for the termination, next slide. So rules under the MTP Act 2021, the composition of medical board, what we are discussing in the previous slide. So the medical board has 3 members, which is 1 gynecologist is necessary, 1 pediatrician, or one a radiologist or a sonologist. With these 3 group, they will form a medical board. Next slide. So what are the powers of this medical board? To allow or deny the termination of pregnancy beyond 24 weeks of gestation period only after due consideration or ensuring that the procedure would be safe for the woman at the gestation age, or whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So this is the this will give a permission in these situations to terminate the pregnancy. And second, the medical board has a power to co-opt the other specialists in the board and ask for any additional investigations if required for deciding the termination of pregnancy. So the medical board has another power that it can ask the further investigations, whether your application is good, is correct or not. It can decide, and it will give the after confirming the situation, then only it has an authority to give an permission. So it has 2 authorities. It can give as itself, it will gives the permission to do MTP, or else it can hold any investigations to whether your application for MTP is correct or not, it can decide by the investigations. So note that FOXI with the ministry guidance and WHO support as a part of respectable abortion can operationalize and host medical board information on website. And next slide. And what are all the functions of this medical board? The functions are 3. One is to examine the woman and her reports who would approach for medical termination of pregnancy. So it will examine the woman and her reports, whether they are correct or not, whether her gestation is correct or not, and it is beyond the 24 weeks. So it will examine the woman and it can decide by its own. And second thing is provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. So it will give its opinion on the Form D. So we'll know the Form D. So we have to tick that is the requisitions for the medical termination of pregnancy. So in that it can give a permission or it can reject. And third thing, to ensure that the termination procedure, when advised by the medical board, it is carried out with all safety precautions along with appropriate counseling within the 5 days of the receipt of the request from medical termination of pregnancy. So it will give the permission within the 3 days of applicant looking and receiving the applicant from the MTP mother, means mother who wants MTP, and we can do our procedures within the 5 days. 5 days of the receipt of the request for the medical termination of pregnancy. And here is a note that the FOXI has an important role to play in ensuring there are the functional medical board in every state as it is stated in MTP Amendment 2021. Yeah. Next slide. So these are all the new rules which were amended in our previous MTP Act. So with this, we are the MTP gestation was increased up to 24 weeks with the opinion of 2 RMPs, means 2 registered medical practitioners. And if at all any mother needed about 24 weeks, so she can go for the safe abortion. As the previously she has to go to the court and she has to submit and she has to get the permission from the court, which took us a long time. By the time the mother has to face a mental and physical means insult. Also means psychologically she used to suffer a lot. With this new rules, the mother can easily take abortion beyond the 24 weeks if it is needed. So only the permission is very much made very easy from the local board, that is a medical board. And the fourth thing is here they have been reduced the RMP's eligibility. That is up to 20 weeks is up to 12 weeks is the 1 RMP, up to 20 weeks is the 2, and above 20-24 are also 2. So with this we can do a safe RL, we can extend our services safe abortion to many more women so that we can do a respectable abortion care to the who are seeking the abortions. So please, all the members, please note these new amendments. Please extend your services to the needy women. And here, please follow the post-test after this session and give your feedback. You will be getting the certificate for this respectable abortion care. Next slide. Yeah. So let us make it safe and respectable to the needy women. So thank you. I'll thank the Dr. Santakumari Madam for this prestigious initiation and which is helping our women so much and making part of in this program. I'm very proud of that. And thank you for giving me this opportunity. I'll thank one and all. Thank you. And I'll hand it over to Sriman to go with the other speaker? Thank you.
Sriman, can I go with the second topic?
Yes, ma'am.
Yeah, I'll share my screen.
Okay, ma'am.
Is the screen? Can you see the screen, Sriman?
Yes, madam.
Yeah. At the outset, I thank the Nalgonda Society for giving me the opportunity. So I'll start with the second module. Before I start with the second module, a few things I would just rewind of the first module is that the gestational age has been increased from 20 to 24 weeks, and 20 to 24 weeks is only for the vulnerable women, that which includes only the 7 categories, and we cannot say like for every woman it is like up to 24 weeks. It is only for the vulnerable group, so it is not a blanket abortion to each and everyone. And then 1 RMP up to 20 weeks, and then beyond that it is 24 weeks, it is 2 RMPs, and beyond that the consensus of medical board has to be taken. And then there is like only the medical board comes into play. There is no role of court anymore after the medical board is formed, and shortly the medical boards are going to be formed in every society, in every Fox's society, or to say every district. So going on to the second module. So the second module is overview of the existing guidelines, pre-abortion assessment, medical methods, and the surgical methods of abortion. So WHO guidelines have been formed, and then we have many handbooks like Clinical Practice Handbook for Safe Abortion Technical and Policy Guidance for Health Systems, Medical Management of Abortion. And down the lane, like 2012 to 2019, there have been many books that have come out and guidelines have come out. One such is the adaptation of WHO Safe Abortion Guidelines in India. And other is the landscape assessment of availability of quality of medical abortion commodities in India. So the WHO along with the FOXI has been striving so well in this aspect to give safest of the safe abortions to the women. And also this is a FOXI along with the WHO initiative. And as all we know that there has been a change in the law on 25th March 2021. And the rules have been changed on 24th, and the Gazette has been released in October. So when we are concerned with the guidelines, there are 3 key areas in the management of the abortion. One is the pre-abortion care, second is the abortion care methods, the third is the aftercare, which includes the post-abortion contraception and counseling. So we need to do the medical history, we need to take the medical history, do the physical examination, and laboratory investigations if and when necessary, and discuss about the contraception along with the medical method or the surgical method. And if the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate to her, depending upon the duration of pregnancy, her medical condition. So we have to take care if she chooses a method, it fits to her duration of pregnancy and her medical condition too. So the pre-abortion assessment, as I said, it includes all these 4 parts. And we all know that the gestational age is determined either by the RMP and this LMP, and this corresponds to the physical examination. So the uterus is a pelvic organ till 12 weeks, and 16 weeks it is midway between the symphysis pubis and umbilicus. And we can, we all know the size at 20 weeks, 30 weeks, and 40 weeks. But obviously, in some cases, we have a disparity. The uterus may be smaller than the expected size, or it may be larger than the expected size. Like in case of the multiple gestations, uterine abnormalities, molar pregnancy, the size of the uterus is more. In cases of ectopic pregnancy, missed abortion, inaccurate dating, and then if the woman is not pregnant, then the uterus size is obviously less than the gestational age. So routine laboratory investigations is not a prerequisite for the abortion service, but it has to be individualized depending upon the physical findings. So in case we are in doubt that patient is pregnant, woman is pregnant or not, we may ask for a pregnancy test. If she's anemic, feel that the tongue is pale, then we may order for the hemoglobin or a hematocrit. And RH typing, HIV testing after the counseling, and STI, that is sexually transmitted disease screening can be done if we see like any pelvic infection is there, or we may need to order for any other laboratory if we suspect any medical history that is like she has a kidney disease or a liver disease, then we may need to ask for the renal function test and liver function test. So one thing out of all these tests important is the RH typing. RH testing we need to do because it later on causes a problem, like it later on causes a problem in the next pregnancy in case it causes an isoimmunization. So we need to know about the rhesus testing. Ultrasound is not always mandatory unless we are suspecting an ectopic or a missed abortion. It is not must and should. And ask the patient why she has a thought of terminating this pregnancy, what are the reasons for termination. And then we have to inform that always early abortion is safe and it has to be done with a trained provider, and discuss with them the methods that are available for abortion, explain the risks and warning signs associated with the abortion method, and inform that she can become pregnant within 14 days after abortion if she doesn't follow any contraceptive method. Discuss with her about the resumption of the normal activities, including the sexual intercourse, and do the follow-up care if any other thing is needed. And do document always on an informed that is on a paper regarding informed or a written consent, and a decision to accept the post-abortion contraception should be stressed upon. So counsel her to follow contraception, not to go for further MTPs. And if she doesn't is willing for a contraception, we are supposed to provide the abortion services and we cannot deny the abortion services. According to Government of India recommendations, the medical method of abortion is only permitted till 9 weeks. So up to 9 weeks, we have the combined mifepristone misoprostol regime. Mifepristone is given on the day 1 200 milligrams orally, and then after 24 to 48 hours, misoprostol 800 micrograms is given either sublingual, buccal, or vaginal or oral route, either of the 4 routes. In case if the pregnancy is from 7 to 9 weeks of gestation, it is the same, but only thing is misoprostol cannot be given orally because it is less effective when given orally between 7 to 9 weeks, and we have we may land in incomplete abortion. So oral route is excluded in 7 to 9 weeks gestational period. So in the global recommendation, less than 12 weeks, we can mifepristone, misoprostol, or misoprostol alone, or the vacuum aspiration are the methods of choice. If it is more than 12 weeks in global recommendation, it is mifepristone, misoprostol regimen, or a misoprostol alone regimen, or a dilatation and evacuation. We should all remember that dilatation and evacuation should not be followed by a sharp curettage. So no curettage. And coming to the other method is the surgical method also. Apart from the medical method, we have the surgical method also, which I will discuss after the medical methods. So the mifepristone is an antiprogesterone, inhibits the action of the progesterone, and it interferes with the continuation of pregnancy by causing residual necrosis. And after we give the misoprostol, that is 24 to 48 hours, misoprostol causes cervical softening, uterine contraction, and the expulsion of the products of conception. So the mifepristone is given on day 1, 200 micrograms orally, and if she is RH negative, we are supposed to give the injection anti-D. 50 micrograms is sufficient, but if 50 micrograms dosage is not available, then we may need to go for a full dose, that is 300 micrograms. And mifepristone, this is misoprostol. Misoprostol is administered on day 3 up to 7 weeks. It is sublingual, oral, vaginal, or buccal, that is 400 micrograms of misoprostol is given. In 7 to 9 weeks, 800 micrograms is given, either sublingual, buccal, vaginal, no oral route. So in addition, we may need to give analgesics. If she has a tendency of vomitings also, we can advise her to take an antiemetic, and always discuss regarding the contraception because it is the best time where she can accept it and follow. So on day 15, that is a follow-up day, we have to confirm the completion of the procedure. And again, if she doesn't think about any contraception, we need to talk regarding the contraception again. So this is regarding the misoprostol, that is already either of the 4 routes as discussed previously, that is oral, buccal, sublingual, vaginal. So in the oral, the pills are swallowed. In buccal, the pills are placed between the gums and the cheek and swallowed after 30 minutes. In sublingual, the pills are placed under the tongue and swallowed after 30 minutes. In the vagina, we have to keep it in the deepest portion of the vagina, that is in the fornices, and the woman is instructed to lie down for 30 minutes, after which she can get up. And we have to remember that the oral and the sublingual routes, there is a fast absorption in the and the plasma levels are reached very fast. Hence, there is increased complications of the side effects like fever, chills, diarrhea, vomiting, compared to the buccal and the vaginal route. This has the fastest onset of action and highest plasma concentration. And compared to the sublingual and oral, the chills are very less in the buccal route and still less in case of the vaginal route. So the vagina, the complications and the side effects are, the side effects are comparative very less when we compare it to the oral, buccal and the sublingual route. So this is a figure showing that where to place the misoprostol tablets between the cheek and the teeth, that is in the gums, besides the gums, and this is underneath the tongue. And WHO recommendation is in case of less than 12 weeks, 200 micrograms per orally, 200 milligrams of mifepristone followed by 800 micrograms, buccal, vaginal or sublingual. There is also another protocol, that is misoprostol only protocol, that is 800 micrograms buccal per vaginal or sublingual. So the vaginal bleeding may continue for 2 weeks, and this is quite normal. And the bleeding, like we need not worry unless the patient has fever, very severe crampy pain, or she has some foul smelling discharge. In all these cases, we need to ask her to come back. Otherwise, 45 days of the bleeding can occur in some of the patients. So the services of medical methods, that is, we can give the tablets at the primary care level, but in case of the complication, we always need to refer to a higher center. So additional services like counseling and testing for sexually transmitted diseases, abuse support services, psychological or social services, and other specialist health and medical services can be provided to them. In case of anemia, provide them with iron tablets. In case of pain, provide them with pain medications or analgesics. And over and above, we need to support them very emotionally. So that routine follow-up is not necessary unless it is an complicated case. If it is uncomplicated, that she has the abortion normally, that is, she has a bleeding after the insertion of the misoprostol, no fever, no abnormal discharge, routine follow-up is not needed. We need not ask her to come back. But in cases like where we need to counsel her regarding the contraceptive services, where we need to support her emotionally, address her medical concerns, ask her to come back after 7 to 14 days. And a routine follow-up visit is recommended in cases of misoprostol regime, that is only misoprostol when we give without mifepristone. She is supposed to come back, and then we need to see whether the abortion is complete. Assess the woman's recovery and ask her for any signs or symptoms of ongoing pregnancy in the follow-up care. Review any medical records, and if she has any medical records, go through them and refer, and also the referral documents. And ask her about the symptoms that she experienced during the procedure, like whether she had any vomiting, pain, how was the crampy pain, how bearable it was, and also focus on the physical examination if she has any complaints, and assess the woman's fertility goals and need for contraceptive services if we have not discussed with her prior. So in summary, regarding the medical methods of abortion, we need to do a physical pelvic examination, confirm the eligibility, that is the gestational age, whether she is 7-weeker or a 9-weeker. Then we need to give her the mifepristone tablet 200 milligrams orally and offer her anti-D injection if she is Rh negative woman, either 50, if 50 is the best. If it is not available, we can as well go for the full dose of 300 micrograms. Ask her to come on day 3 for misoprostol, and give her the address, phone number of the facility if she has to report in case of any emergency. Ask her to record the experience of any side effects on the MMA card which we give her. 3% of the women expel, most of like 3% of women expel the products of conception totally, but we need to give her the misoprostol either orally, vaginally, buccally or sublingually to complete the schedule. The second visit is on day 3. Give her the misoprostol 400 micrograms. Observe for 4 hours in the hospital, either in an emergency room or a casualty room. Analgesics like ibuprofen can be given and discussed regarding the contraceptive options, that are condoms and hormonal methods. The mean period of bleeding is about 8 to 13 days, and possible side effects would be the nausea, vomiting, diarrhea, headache, fever, and dizziness. Report in case of excessive bleeding, pain, abdomen, and fever. Ask her to report if there is no bleeding also, which indicates that the abortion process has not started, and consider her to give 1 more dose of misoprostol. And 75% of the women abort within 4 to 6 hours after the misoprostol administration. That is why we ask her to stay back in the hospital for 4 to 6 hours. So day 15, pelvic examination is done to ensure the completion of abortion. And the contraceptive options are given to her for hormonal method, condom, IUCD or sterilization. Sterilization can be done after 1 menstrual cycle. And tell the woman that the fertility is going to return in next 14 days and report back if she does not have period in the next 6 weeks after the completion of the abortion process. And she may become pregnant if she doesn't follow any contraceptive method. And ultrasound examination is only advised in case we have a doubt that the process is not complete and any bits of conception are retained. The side effects and complication includes pain, nausea, vomiting, diarrhea, and infection. Never be judgmental regarding the pain and give her verbal support, give her adequate counseling, tell her cramping pain or a period-like pain is going to be there, and ask some person along with her, like an attendant, to support her. Give her ibuprofen 400 if she has pain. In case of persistent pain, we have to suspect ectopic pregnancy or an incomplete expulsion of the products and ask her to come back. And nausea, vomiting, diarrhea are self-remitting, so reassure her. In case of infection, physical examination is done and antibiotic coverage has to be given. In case of failure of medical method of abortion, we may repeat the dose, that is same mifepristone misoprostol can be repeated, or we can offer a surgical method, that is a vacuum aspiration. In case of incomplete results, that is bits of products of conception are retained, we can observe her unless there is heavy bleeding. If the bleeding is resolved and the uterus is normal, it indicates the abortion is complete. And we can as well repeat the dose of misoprostol to complete the process of abortion. And if the patient opts for a surgical abortion, we can as well go for a surgical abortion, or in cases of heavy bleeding, we can opt for a surgical evacuation too. So if a woman presents to our casualty, if a woman comes with the casualty with excessive PV bleeding more than her menstrual cycle, that is on day 3 after we give her the misoprostol, she goes home and then comes back with the excessive bleeding, then we have to examine her again. So if the bleeding is more than her menstrual cycle, or if she is soaking more than 2 pads in 1 hour for 2 consecutive hours, she has to report to us. This is the excessive bleeding. So she has to report back to the casualty. And if the bleeding decreases while we are examining, then we can just as well leave her, just monitor her for next 4 to 5 hours and we can discharge her after that. But if we are if she is bleeding, then we do a PV examination, and if the products are felt in the cervical canal, and we can do a digital evacuation, and the products have come out, then if the patient is stable, we can as well observe her for 4 to 5 hours and discharge her. But if the bleeding continues, we need to do an ultrasound examination. If only minimal bits are there, we can wait and watch. And if the pregnancy is continuing, better is to go for a vacuum aspiration. But if small bits are retained, or then if the woman is not stable, we can go for we have to go for a vacuum aspiration. There is no other go. And if the woman is stable and little products of conception are there, we can give misoprostol 600 micrograms orally, or 400 micrograms sublingually we can place, and then we can ask her to come back. And medical method of abortion comes under the purview of MTP Act, and we need to document it. So it is mandatory to fill all the forms, what we do for the surgical methods. That is the Form C is the concern form. Form 1 is the RMP opinion. Form 2 is the monthly reporting form which we send to our district authorities or the DMHO. And Form 3 is the admission register for case records. And Form 3 or the admission register along with the concern form and RMP form remain with us. All these are to be kept under lock and key. And so coming to the surgical methods of abortion in the first trimester, vacuum aspiration is a recommended technique of surgical abortion for pregnancies up to 12 weeks. And WHO has recommended that the manual vacuum aspiration to be the safest, and the procedure should not be routinely completed by sharp curettage as it damages the endometrium and also decrease the number of cases of the Asherman syndrome. So the vacuum aspiration method works on the principle of creating vacuum and aspiration of the products of conception. This is a handheld vacuum aspirator, and the cannula is attached to the aspirator, and then the products of conception are aspirated. So the cannula can be, this set can be used for multiple times. As it is a manual one, it doesn't require any electricity, and it can be used in low setup also. So the size of the cannula which we use corresponds to the weeks of the gestation. That is 8 mm cannula for 8 weeks and 10 mm cannula for 10 weeks. This is the electric vacuum aspiration machine, what we have regular in a notice to aspirate the amniotic fluid during cesarean sections, and also for the vacuum cups, what we use for the instrumental delivery. So this is an electric based pump, and it creates the vacuum, and we are used to use the proper aspirators that we can connect to the tubing. And regarding the cervical priming is basically to make the cervix soft and easily dilatable. And this also helps in easy insertion of the cannula. And apart from it, in all the scarred uterus, it prevents the ruptures also. So cervical priming is one of the important things we need to do in cases where we anticipate the cervix will not dilate easily. So we can use oral mifepristone 200 milligrams 24 to 48 hours in advance, or misoprostol 400 micrograms administered sublingually 2 to 3 hours prior to the procedure of surgical evacuation, or misoprostol 400 micrograms administered vaginally 3 hours prior to the procedure, or laminaria trends which can be placed intracervically 6 to 24 hours prior to the procedure. So the pain management includes this is an important component for the quality abortion care, and it reduces the pain, anxiety, and makes the woman very comfortable. The two components of the pain management are the non-pharmacological, or in case of a pharmacological, where we use medications. So the non-pharmacological pain management is providing psychological support, explaining each step in advance, and performing the procedure gently and smoothly, encouraging the woman to breathe in and breathe out and relax in between. So the pharmacological pain management includes anxiolytics or general anesthesia. We can give anxiolytic like diazepam 10 milligrams orally 1 hour prior to the procedure, or 2 to 5 milligrams IV over 20 minutes, that is very slowly prior to the procedure. And for the cervical dilatation, we can go ahead with the paracervical block, or we can give analgesics like 400 to 800 milligrams 1 hour prior to the procedure, where the analgesic, the patient cooperates a little bit because the pain reduces. And therefore, if the patient complains of uterine cramping, we can as well go for analgesics like 400 to 800 grams of ibuprofen prior to the procedure. So we prepare the instrument that we need to close the walls and create the vacuum. And the pain control medication, as I discussed in the previous slide, we can give a pre-procedure medication like ibuprofen. And the cervix is cleansed with the antiseptic solution. A paracervical block like 10 ml of lignocaine is given at 4 and 8 o'clock position, and the cervix is dilated. The cannula is inserted, and we need to withdraw. Once we go to the fundus, we need to withdraw 1 to 2 centimeters from the fundus to prevent perforation. We rotate the cannula in a quarter turn, that is 10 o'clock to 2 o'clock position, that is with a very gentle slow motion, and release the vacuum button on the aspirator, and we see the products of conception coming out of the cannula. So once again, so how do we know that uterus is empty? Pink and frothy pink products with red or pink frothy foam without tissue passing through the cannula is one of the signs showing that the uterus is empty. Gritty sensation over the surface of the uterus, cervix gripping over the cannula, or the uterus contracting around the cannula with increasing uterine cramping pain. All these four indicate that the uterus is empty. We need to inspect the tissue which comes out from the cannula into the aspirator. And also, if the patient agreed for IUD insertion, we can go ahead with the IUD insertion. Or if she wants sterilization, that is a tubectomy, we can go ahead with the tubectomy. And instruments have to be cleansed with 0.5% chlorine. This removes the tissue also, apart from disinfection of the cannula and the aspirator. Post-procedure care, monitor her for any complications and provide management as needed. She may leave the hospital once she is stable and meets the criteria for the discharge, and ensure that the woman has taken all the medication and information before she leaves the hospital. Document the treatment and the procedure, what we have done, and also give her the record when she has to return, and in case of emergency, where to return. Aftercare is regarding the management of the abortion complications, that is, if in case of incomplete abortion, infection, bleeding, ongoing pregnancy. Provision for contraceptive information and the contraceptive counseling and method has to be done thoroughly. And assessment of the sexual and reproductive health, that is, in cases of STD, screening can be done, and we can talk about when she's planning. She can really come back for preconceptional counseling. And follow-up, there is no need for follow-up unless it is a meso alone regimen. So in summary, India has made historic progress in improving the access to safe abortion. And India is one of the first countries to legalize abortion, and also to bring about so many changes that have been brought in the last year. But the thing, like, we do not have much changes in technology updates and the methods, but surely we have the safety methods and the quality we can give to the patients. And over and above, we can do it very respectfully. And every client, maybe it is a private client or a public client, it doesn't matter. We need to give her proper information, proper method and counseling. Everything has to be done properly in spite of the client being a private. Any client is same to us. So give her a respectful abortion services, ensure that she takes proper counseling for contraception. So please do the post-test also, give the valuable feedback, and then you will be awarded with the certificate by FOXI and the WHO. Thank you so much.
Susila, there's a question in the chat box. Ideal antibiotic of choice in case of infection?
Yeah.
Ideal, yeah.
Yeah, you please answer, ma'am. After that, I'll say.
Sure, stop share. 1 second. I'm just trying to stop share. Where do I do that, Padmaja?
Go on to the top. You'll have your green button. Move the mouse to the top.
Chat. That's it.
View options. There you can stop share.
Stop sharing.
It's not coming there?
No, I'm not. Yeah, 1 second. Yeah, I got it. Yeah. So what is the question, Padmaja?
Ideal antibiotic in case of infection.
In case of infection, we need to go for a broad spectrum antibiotic. Better is go with the ATM. ATM is amikacin, taxim, metrozole is always better. But before we go for the amikacin, definitely we should see with the renal function test.
Thank you, madam.
Yeah. Thank you, Susila Garu, for your excellent narration of the module 2. And it's a respectable abortion care in first trimester, both medical and surgical. Thank you, madam.
If they would like to ask, because I need to go for the another RAC program at 4 o'clock.
Yeah, please, ma'am, you can. Please,
Thank
ma'am.
Bye, Padma.
Thank you, ma'am.
Dr. Shah.
And we'll move on to the third module by Dr. Padmaja Garu. Please, ma'am, onto the screen and please continue with your module.
Just a moment, I'm doing that.
In between, if Down syndrome confirmed by amnio, is MTP legal? Yeah, it is legal.
Yeah.
And one thing I would like to say is, we see for the NT scan, we go for the NT scan, right?
Yes.
So if the NT scan, we have a doubt, then we go for the screening test. And then confirmatory test. That is like even like before 24 weeks. So there is no need to go for a medical board also. We can as well do, because they come under the vulnerable group, we can as well go for an MTP.
So, good afternoon, everybody. And I thank the Nalgonda Society and Foxy for giving me this opportunity to interact with you all. You've just heard our two esteemed speakers talk about what are the new rules, what are the new laws, who can do it, where it can be done, and what are the women who can be offered at different periods of gestation. And Dr. Susila has very nicely covered about how to do it. I'm doing a more softer topic where we talk about the excuse me, rights and respect in this model. So here we expect this module, the aim is all of you gynecologists, right from the time of MBBS, all of us know how abortion should be done. There is no question about the science behind it. All of us will do good care. But what we need to start making a change in the way we do things is, we need to follow the WHO standards to offer respectful abortion care. And we need to remember that however good a service we are giving, there are a lot of norms and stigma that is associated with abortion, and we need to try to tackle that. And the resources for this respectful abortion care. The momentum has been created by changing the law, and this is being disseminated to all the OB/GYN providers. Foxy being the largest provider, these online classes, because of the COVID, it is reaching all the providers. Now we have a huge network and everyone is familiar with online. And we need to recognize that with the increasing uptake of medical methods in a pregnancy that is not wanted, early and safe abortion service can be provided. And in this way, there will be absolutely no conflation along with there's no conflict of interest with the PCP and DAT Act, because at that 8 weeks, 9 weeks, there's no question of any sex determination being done. And patient safety, respect, and quality matter more than ever now. So that is why we all have a role to play. WHO says respectful abortion care means that we need to maintain safety first, the dignity of and the confidentiality of the woman, so that the woman is free from harm and mistreatment. She is enabled to make informed choices, and we are going to provide her continuous support during and after all types of abortion. So in simpler terms, respectful abortion care means we as a provider treat the patient with dignity, empathy, and compassion, irrespective of our race, ethnicity, gender, socioeconomic status, and reproductive history. The reason why this was said is somewhere inherently, sometimes when we know that a woman has taken a medical abortion and within 3 months she comes back again, and this is her 4th abortion, maybe we will be a little looking down on her, but that we should try to avoid, because we don't know the circumstances in which she is there, and a woman is adult enough to decide when, how, with whom, how many children she has. It's her right, and we shouldn't be judgmental in that. But it is also important that when something is not right, something we need to Because, and as a healthcare professional, it is our duty to listen and support. Therefore, communication is the key. So, as we were telling you, what are norms and stigma? This is
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So you've just heard that beautiful video where stigma and norms are there. Basically, the problem with this is they perpetuate disrespect and abuse. The worst form of abuse can be physical abuse, intimidating physically. Verbal and sexual abuse are no less bad. Stigma and discrimination are forms that are not so well thought out, but we need to remember as healthcare providers, when we don't meet our professional standards, do not have a rapport with women, and our healthcare systems and conditions constrain us, even this comes under a sort of abuse. The right of every woman is freedom from harm and ill treatment, right to information. She is protected by the laws of MTP and POCSO. She has a right to informed consent and a refusal at any point of time. She can change her mind. And we need to respect her choices, preferences, give her the dignity and good quality of care. Our responsibility as healthcare professionals is to provide timely and right healthcare to the highest attainable level of health, and it should be free from coercion. So essentially, reiterating what all we've been telling, in respectful abortion care, the woman has a right to be free from harm, mistreatment, maintain her privacy, confidentiality, preserving her dignity, respecting her choices. We need to develop skills of effective communication so that we give adequate information and then take an informed consent, give continuous access to support, enhance the quality of the physical environment and resources, equitable abortion care. Whoever needs it should be given. And we are already competent, we should be motivated. Along with all this, continuous provision to contraceptive advice and counseling is what we need to do. We need to strengthen this implication when up to 20 weeks, when only one provider is giving the care. It is a more responsible position, because it is the responsibility of this healthcare provider to give counseling, contraception, referral, and also be compassionate. As we were already telling, 2 medical practitioners are necessary between 20 to 24 weeks, and beyond 24 weeks, if there is a lethal anomaly, we can take the help of the medical board. The change has also been in getting the extension to 20 to 24 weeks for women in special cases. All women can seek a pregnancy termination till 20 weeks. And we need to be mindful of all these socio-cultural aspects, and remember that only when we respect the women that we will get back the respect. And confidentiality and safety are the prior things. Let us look at what type of language we should be avoiding, because sometimes we don't realize that.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So we also have a guide to avoiding stigmatizing language, and this is very brief.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus.
WHO also provides a safe abortion values toolkit. In this,
no woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So there are self-paced games which you can also try it out. From the 1970s, we did have abortions, but quite a large number of abortions were unsafe because people did not know about it. In the 2000s, we started off with improving safe abortions, and in the 2020s, we are looking at respectful abortion care. So for those of you, we are hoping you did not nod off with all those videos and the nice sound post-lunch like a lullaby. So we have some recap questions. And we want answers in the chat box quick. According to the World Health Organization, restricting access to number of safe abortions. Restricting access reduces number of safe abortions. Is this true or false? Dr. Manjula, we are getting the answers in the chat box because I can see only this screen.
Yeah. I'm seeing the chat box.
Yes. So if we restrict, will the unsafe abortions come down? Is it true? Is it false? So I quite a large number of you.
They are saying false. They are correct.
So definitely it is false. And we consider it a safe abortion only when the right person, right method, and right registered place is there. All three pieces need to be met. Okay. And under the MTP Amendment 2021, a minor of less than 18 years, when she wants to undergo termination of pregnancy, is it necessary to attain a written consent from the parents and guardian?
Yeah, so true, ma'am. True.
The clause has changed, Dr. Garu. You don't need parent or guardian. Okay. What we need is an adult who is willing to stay with her and take responsibility. Now, suppose there are nowadays very young girls who are staying in hostels who might want termination, but if we insist on them coming with their parents and guardians who they don't want to share this information with, they will go into for an unsafe place. So what we need is not the parents. It does not need to be a guardian. It needs to be an adult who is willing to take responsibility for her health. But remember, she is less than 18. So we need to report under POCSO. Abortion service should not be denied. And we need to provide bias-free services without judgment. A 30-year-old, this is another case scenario, where a 30-year-old woman who's recently widowed wants to get an abortion at 22 weeks. So as a provider, we know at 22 weeks, in a short time, the baby will be viable. But what is our responsibility? Do we tell her to continue this pregnancy? So do we have quite a large number of answers? We don't ask her. We don't insist that she continue because it is her choice. But because it is 22 weeks, we need two medical practitioners to sign off on that. In India, abortion is legal. So let us make it safe and respectful. What we want is a Sammat and Sampurna Bharat, where safe abortion, respectfully available throughout the healthcare system, is what we are looking for. Thank you for sparing the time and listening to me.
Thank you, Padmaja Garu, for your well narration of the module 3, so that the audience has been acknowledged their means they improved their knowledge about the abortion safety, what is a respectable abortion. So how we have to treat an abortion woman or a girl with the due respect to her dignity. Now we'll move on to the, I think no questions, I think so, from the audience. In the chat box, we didn't find any questions, ma'am.
I only
we'll
asked
move
all
on.
the
Has cleared
questions,
all
no,
the doubts.
Angela. So they didn't have
Excellently,
time
she
for
has
questions.
cleared all the doubts.
Yeah.
Yes,
Now we'll
yes.
move on to our last module with the speaker is Dr. Shaili Agarwal from Kanpur Society. Please, ma'am, please go through with the last module in a
Is it
respectable
visible?
abortion care training. Yes, ma'am.
Okay.
Yeah, the
You're
screen is visible,
audible.
ma'am. You are visible and you are audible, ma'am.
Thank you so much. So thank you, Dr. Manjula.
Please increase your
And
value,
Alpha
madam.
Society.
Please
Yes?
increase your value.
Shriman, mute everyone else.
Is it okay?
Yeah. Okay,
So
ma'am.
I congratulate all my speakers, Dr. Manjula, Dr. Padamja, Dr. Sushila, for wonderfully covering each and every aspect. And now we have moving on to the last module, that is not moving, Shriman. Okay.
Yeah.
So we are now in the counseling part. To implement each and every program, the success depends on how well you counsel your patient. So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and a guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perception. So this is the two-way communication between the provider and the client. So we are talking about the pre and post-abortion counseling. This is an integral part of comprehensive abortion services. It is equally important as the procedure itself. It helps the woman in making the decision, making the right choice for her, and whenever needed, the spouse of the female should also be counseled in the same setting. Sorry. So, counseling should be done prior to procedure, during the procedure, and after the procedure. It has a critical role. It helps the woman to decide about the termination of pregnancy and also helps her to choose the right method for that termination, and also ensures the delivery of complete information about that procedure, what are the safety, what are the risks associated with the procedures, and also help the woman to adopt a proper contraceptive method, an effective contraceptive method to prevent further unintended pregnancies. So what is the procedure of pre-procedure counseling? First and foremost is you have to ensure the privacy and confidentiality. There should be a separate room for the counseling. Then be non-judgmental and sensitive. As Dr. Padmaja has very beautifully elaborated, if the patient is unmarried girl or even she is a sex worker, be non-judgmental and be sensitive to her needs. Establish a rapport with some non-verbal communication means like look into her eyes, greet her properly, make a smiling face, do not indulge in other activities, and then use simple language which the patient or the woman understands clearly. We should not use very medical terms, very scientific terms. We should use the common day-to-day language. And if she has made up her mind for the termination of pregnancy, assess her for the procedure. So the relevance of peri-abortion family planning counseling is because after the abortion, return of fertility is very quick, within 10 days to 4 weeks. We all know that. So during this time, she needs an effective contraceptive, and we have this opportunity to counsel her regarding that family planning method. And if she is having abortion this time, it should be a minimum 6 months gap before next pregnancy to ensure a healthy outcome of next pregnancy. It is a WHO recommended guideline. And also we should discuss the health benefits and better pregnancy outcomes with the patient. So pre-abortion counseling, when to start? Whenever patient visit us, first visit itself. Sometimes there are some situations, some grief situation in which we can delay it. Otherwise, first visit is the ideal. We have to counsel her regarding the return of fertility. What are the choices which are available? And if she has chosen some method, then what are the specific benefits or risk of that method, and sometimes high risk behavior like if she is sex worker, then use of dual method to protect her from the sexually transmitted disease. But if after your counseling the patient is not willing for any contraceptive method, you should not refuse the MTP. Sometimes the patient, our junior residents, they say, ma'am, she is not opting for any family planning method. We have refused her. We will not do the MTP. But it is her right. It is her right to assess for the abortion care. We should counsel her properly so that she should opt. Then, assessing the suitability for post-abortion contraception. The general rules are, when your abortion process is complete, you have ensured the safety, the cleanness, all the aseptic precautions so that there will be no infections, no injury to genital organs, and the chances of fresh pregnancies are ruled out. This is the right time to go for the post-abortion or post-procedure counseling. Ensure that woman has understood the precautions and the care needed during the post-abortion period. Like if you have asked her not to do sex for the 7 days period, 10 days period, she should understand it properly. And proper use of antibiotics if you have prescribed her. Then this is also an opportunity to counsel for the contraception. If it was not previously, she has not adopted, yes, she has not accepted prior to that procedure. And also reinforce the need for continuing the use of contraceptive method she has chosen, because the proper uses, continuous uses of method is also very important. Then you have to continue to ensure the privacy and confidentiality even after the post-procedure counseling. You have to reassure her case in case of any problems, like if there's an infection or there's a genital trauma, you have to reassess her or reassure her. Then you have to repeat the information about the post-procedure care and danger signs again, even although if you have discussed it in the pre-procedure counseling, again at the time of discharge you should emphasize on that danger sign when she has to come back. If there's excessive bleeding, she is having pain, she is having fever, she has to report to the site accordingly. So now come to the post-abortion family planning counseling. If she has adopted a method prior to that counseling, prior to that abortion, you should appreciate her, because appreciation makes her encourages her to continue with that method. And then immediate care. If she has adopted for IUCD or MPA, you can provide it in the same sitting also. If she has opted for oral pills, you have to tell her how she has to take the pill regularly at the same time every day, and do not miss her pill. Follow up the protocols, and then continuity. Ask her for the follow-up visits and give her cards in which all the informations are given in a simple language. If she has undecided what method she will choose, this is the time to relieve her anxiety, and then also reinforce the importance of adoption of any method of family planning. And then you can say, if you have not decided yet, you can come within 7 days and then you can choose another method. And this time the importance of spouse is very much. You should do the couple counseling. Both of them can take a decision. Even if she has not decided, you should provide her with the emergency contraceptive pills option also. So they are the one by one. We will discuss which method she can use and how. Suppose she has chosen the barrier method. So after abortion, after first trimester abortion, she can use the condoms as soon as the sexual activity is resumed. Also after second abortion, same. But additional information is, it is having no hormonal side effect, but it is non-hormonal. It can be used without consulting the healthcare provider. It is easily and freely available. It prevents against the STIs, including the HIV, but it enables men to take the responsibility of contraception. It is not in the hands of female. So we should give all the information. If she has chosen the intrauterine contraceptive device, then In the first trimester abortion, it can be inserted immediately or up to 12 days after the confirmation of the completion of the abortion using the surgical method with MMA. If she has choose the medical abortion, then it can be inserted on the day 15 of the process. But you have to be ensured that all the products has been expelled, there is no RPOCs, and there is no risk of infection, and other contraindications are all ruled out. Likewise, in second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete, and contraindications like infection or other are ruled out. Additional information we have to give that it is highly effective. It provides a long-term contraception. If she has chosen IUCD 375, it is for 4 or 5 years, and 380 is for 10 years. It can be provided by a trained MBBS or MS or even ANM who has trained in inserting the IUCDs in first trimester abortions. And it does not interfere with the sex, and when she wants to get pregnant, just after the removal, it is immediate return of fertility, and it has having no hormonal side effects. If she has opted for the hormonal contraception, OCPs, then it can be started immediately or within 7 days after the abortion using surgical method. If she has opted for the MMA, medical abortion, then it can be started on day 3 with the dose of misoprostol, or within the 15 days of the process after the confirmation of the completed abortion. After second trimester, she can use immediately or within 7 days of abortion. But additional information has to be given. It also helps her in regulating the menstrual cycle. It can be provided by all healthcare workers after the first screening by a trained provider. It doesn't interfere with the sex. It also protects against ectopic pregnancy, endometrial and ovarian carcinoma, and also benign breast disease like fibrocystic disease and fibroadenomas. But it is not suitable for the women who are breastfeeding babies which are less than 6 months old. So we should also inquire whether she is lactating or not, how old her baby is. So all these things has to be taken into consideration. If she has chosen a long-term injectable, that is MPA, it can be given immediately or within 7 days after the abortion. With MMA, it can be injected on the day 3 when we are giving the dose of misoprostol. In second trimester abortion, it is immediately or up to 7 days after abortion. Additional information which should be given with this MPA is, it is highly effective, it is confidential, and the privacy is maintained. It can be provided by a doctor, MBBS or above. Even Ayush, ANMs and nurses, they can provide this injection, but screening should be done by a doctor for the first injection to rule out any contraindication or hypertension. It does not interfere with the sex. It has no effect on the quality and quantity of breast milk, so it is safe for the lactating mothers. Though there are the myths that it reduces the bone mass, but it is reversible. And also it helps in the protection of ectopic pregnancies, ovarian cancers, iron deficiency anemias, and uterine fibroids. Then coming to the permanent method, that is female sterilization or vasectomy. After first trimester abortion, it can be performed simultaneously with the procedure itself after ruling out the infection or severe blood loss, or it can be done within 7 days by both the method. It can be done via laparoscopic or it can be done by a mini lap technique. If she is having a medical abortion, it should be deferred until she has got her first cycle. After second trimester, mini lap can be done immediately or within 7 days after the abortion, ruling out the infection or severe blood loss. But after second trimester, laparoscopic is not recommended. We should opt for the mini lap technique. So it is a permanent method of contraception. It cannot be reversed. It is highly effective. It is effective immediately, no interference with the sex, no effect on the breastfeeding, no long-term side effects, and it also protects against the ovarian cancers. Vasectomy can be performed on male independent of the timing and procedure of the abortion. It is also very effective. It is a permanent method. There are no long-term health risk to the husband, But couple must use another method for initial 3 months until the male is declared azoospermic by the semen analysis. So this is a chart. After MMA, we can use the COCs, injection, and centromone, that is ormaloxifene, on the day 3 when we call the patient for the misoprostol dose. COCs can be started any day between day 3 to day 15. IUCD can be inserted after the 15 days after completion of the procedure. After the MVA, that is manual vacuum aspiration, COCs, injections, centromone, IUCD, tubal ligation, all can be done during the procedure itself or within 7 days. With IUCD, we have an extra window of 5 days because it also acts as an emergency contraceptive. So in which the IUCD, we can go up to 12 days. So a few things about the safe reproductive health services. During this COVID era, we all are familiar with the teleconsultations and tele-OPDs, EOPDs, and other technologies. So few words about them. So it can be teleconsultation, it can be telecounseling, it can be tele-guidance, tele-reference, and tele-linkage. There are some websites by the Government of India, Hamdo, and on social media there are the sites Ask Tanu or YouTube. They have a very important information and material, education material available. And there are some patient education platforms provided by the WHO, Ministry of Health and Family Welfare, and RCOGs, which women can go and search for the answers. But there are some, each and everything has some strength and some weakness. So sort of teleconsultation is strength are during this COVID era where there was complete lockdown, there was no transporting facilities. We were able to give consultation to our patients through this teleconsultations. It was approachable throughout the process. It is confidential and awareness was there. They can question their doubts and they can get the answers. But it was having some weakness also. Like it was not a feel of face-to-face communication, and demonstration was not very up to that mark during this teleconsultation. Opportunities, it is private, it is comfort, it can be done at the comfort zone of your home. It's cost saving because it reduces the cost of transportations. Number of visits were cut down. But sometimes with the teleconsultation, we were not able to see the patient properly. We are not able to examine her physically. So sometimes the diagnosis can be missed. So applicability of component of CSC, we can do the assessment, we can confirm the diagnosis. We can also ask for the contraceptive need, whether she wants a spacing method or she wants permanent method. And then video conferencing or Zoom, we can do the counseling, we can tell her various methods available and follow up by the hybrid services. She can come to us for one visit and the rest visits can be done on the teleconsultation. So the key messages are, we all, as a gynecologist, we should realize the need for post-abortion family planning, and we should not miss the opportunity to counsel our women during this particular phase. Bring the couple on the board and strive for the 100% coverage. Capitalize on the basket and applicability on post-abortion period. We have a huge basket of contraceptive which the patient can choose according to her priorities, and we can guide her what is best for her. Technologies, as far as possible, we have understood the scope for entry in the CSC services by method of this teleconsultations and tele-OPDs. And adolescent reproductive health needs both online and offline. Now we can reach thousands and thousands of girls through this media, which is not possible on the face-to-face or physically. So we should take the advantage of these technologies. I request all the participants to please stay here for the post test and the feedback. You will get the certificate only after you have submitted your post test and feedback. Otherwise, you will not able to get your certificates. So let's make it safe and respectful. Samarth Bharat, Sampurn Bharat. And I congratulate Dr. Shanta Kumari Madam for this wonderful initiative. And thank you so much.
Yeah. Thank you, Shaili Agarwal, for your excellent talk, means excellent narration on the module 3B. And now I'll request all the participants, please stay for your post test and the feedback. Meanwhile, you can post your any queries in the chat box, or else you can unmute yourself and you can ask our eminent speakers to clear off your doubts if you have any.
Madam,
There was a question, what is the procedure to refer to medical board in case of anomaly detected after 24 weeks? So each and every state has its medical board. Government of India has issued the guidelines to make the boards, and each and every district is having board. So it will be circulated very soon to all your societies. Have you made the board, ma'am?
No, ma'am. No, ma'am. Not at in Telangana. To my knowledge, in our Telangana now. To my knowledge, we are not. I am not concerned about that. Maybe soon we may be having, but not yet now, ma'am. So if at all anything, but whatever the thing we are referring, previously we used to refer about 20 weeks to this child welfare officer, and they are through our Sucharita and our president. So they are responding very well, madam. To one or two special cases we got anmata. We got permission to the medical college, that is through MCH we send anmata. It's a very good response from the child and welfare department, and then we got the permission from the court also, and we the MCH has been done abortion for them. So that's the procedure we are following for the about 20 weeks. That is to be according to the previous act. But now we did not to go, so that the medical board has to form. I don't know.
It has to be formed for beyond the 24
To my
weeks.
knowledge, I didn't have any idea about medical board in my district, madam. And to my other societies also, I don't know. Maybe in future it will do come, I think so, in Telangana. What about Padmaja Garu at your service, at your place? And
yeah, the thing is, we're having the Foxy president and all are having talks with the health secretary of the state, and they're going to form in all the medical colleges and district headquarters.
Yes.
Medical boards are there in Guntur and Ongole, as far as I know. In other places, because it's a state, health is a state issue. So each state will have to form its own.
Yes, each state will form its own.
Yes,
and in each state also, every district will have it.
Yes.
Yes.
We asked our Telangana chapter, madam, about this, and then soonly we'll ask our Nasimha Reddy sir, who is the president of our Telangana chapter, and soon we'll do form our medical board. We'll ask. Any other queries from the audience?
Dr. Shaili, there was one about teleconsultation in the chat box.
What is it, madam? I'm not able to see it.
Teleconsultation is only for limited gestational age.
Yes, because it can be given up to the 9 weeks by medical method. Even if you are sure that she is sure about her LMP, she is sure, and you can see her ultrasound also, reports you can see, but not beyond that, because if the 9 weeks has been limit has been crossed, we have to call the patient and we have to do it surgically.
The thing is, you can talk to them about what teleconsultation. The aim is that the number of visits to the healthcare facility is decreased.
Yes.
You can talk, do the counseling, everything, but for the medication they have to come, and even the second medication you have to do it with supervision, because if there is a problem and a collapse, the medication will be held responsible. So we need to give them in physical, that if these are the problems, if this happens, This is the number. This is the contact place you have to go to.
Yes.
We are really protected only as long as we follow these rules.
Yes. Definitely.
Hi, Rajeshwari. How are you?
Fine, madam. Yeah. Good afternoon, madam.
She's our treasurer, madam, from our Nalgonda Society. Dr. Rajeshwari Praveen,
Rajeshwari.
who is a senior practitioner in Nalgonda town.
So you're taking us on a trip in Nalgonda out. We can see you in a party.
Yeah, definitely.
Okay, good. So
But nice talk, ma'am.
Yeah, thank you.
Thank you.
Shriman has posted a link in the chat box. So
Yes.
people can click on to that link and finish the post-test there. Otherwise, copy that link, keep it on your desktop, do the post-test at any point of time you're comfortable.
Okay? Yeah. If you finish post-test and give your feedback, then only you are getting the certificate to your means whatever the mail ID you have given.
Yes.
Okay.
It will take 1 week to 2 weeks to reach the certificate to you. Yes.
Yes, ma'am. We have to finish our post-test and you can finish within the 15 minutes. Whatever the question was posted by Padmaja, those are the and another 3 or 4 questions are there apart from your personal data. So you can finish it within 5 minutes and you can upload your post-test and then a feedback also.
Okay.
Once again, I am thanking my esteemed lecturers, esteemed faculty, Dr. Padmaja Garu, Dr. Susila Garu from Vijayawada, and Dr. Shaili Agarwal from Kanpur for participating in our RAC training program on behalf of Nalgonda Society. And I'll thank Dr. Santa Kumari Madam for initiating in such a wonderful session, wonderful program, which is reaching each and every part of the country. And we are training more and more obstetrician and gynecologists and also other RMPs so that we can decrease the unsafe abortions and we can decrease the percentage of contribution of percentage of deaths in MMR through abortions. So thank you. Please follow the rules and regulations and acts for the safe of a safe abortion and do safe abortion and do give a better health care to the needy women. Thank you, one and all.
Thank you. With your permission, Dr. Manjula.
Yeah, thank you, ma'am.
See you sometime, Shaili.
Yeah,
thank you so much. Thank you so much.
Thank you, Sriman, for your technical support.
Welcome,
and then, we'll upload our post test. Okay. Thank you.
Okay, ma'am.
Thank you.
Thank you, Sriman.
Manjula madam, I'll be there for more 5 minutes, madam. I have another meeting, amata. So I'll end the meeting after 5 minutes. Ask doctors to just click on the link, madam. A link click cheste they you can leave the meeting, madam. Alage andariki cheppesayandi. I'll be there for 5 minutes, then I'll end the meeting.
Okay, tapakunda.
Okay, ma'am. Thank you, ma'am.
I'll request all the audience, please click on the link which was given in the chat box, and then you can leave the meeting. Thank you.
Click on the link which is given in the chat box and can leave the meeting and
yes.
ఇప్పుడు వాళ్ళు స్క్రీన్ మీద పెడతారట టెస్ట్ తర్వాత ఇది అప్లోడ్ చేస్తే తర్వాత మనం పంపించిన మెయిల్ కి సర్టిఫికేట్
ఇది ఏంటి మెడికల్ బుక్ ఇదిగో పోస్ట్ టెస్ట్ ఫీడ్బ్యాక్ పోస్ట్ టెస్ట్ మెయిల్ According to WHO, legally restricting abortions reduces the number of abortions.
No, false.
Abortion.
In my country, abortion services are governed by Sargarahi. In my
Sorry, disturbing the ఇది ఒకటి రెస్పెక్టబుల్, ఇది పోస్ట్ టెస్ట్ వస్తుంది. ఎట్లా లీవ్ చేయాలి ఇప్పుడు ఈ మీటింగ్ ని?
అదే ఎన్ బటన్ ఉంటుంది మేడం, ఎన్ బటన్ క్లిక్ చేయండి, కిందన యూ కెన్ లీవ్ ద మీటింగ్. Dear doctors, I'm closing the meeting, doctors.